Hi everyone, thank you for joining me again today. This is another episode of Ask the Egg Whisperer. You guys have sent me so many questions and I'm really excited to answer them all. I have over 10 pages of single space type questions. And if you guys have sent me a question that I did not respond to, it would never be bothering me if you just ping me and be like, hello, Dr. Aimee. Don't forget to answer my question. So gather around, we're gonna hang out, we're gonna talk about fertility, and we're just gonna riff and have a good time. I don't know if you noticed, I have new earrings on, and I'm wearing these earrings to remind you guys about embryo diamonds, okay? So this is the information that you guys need to have about your embryos. Think of your embryos as diamond. D for day they're frozen or transferred, I for implantation rate, A for are they abnormal, M for are they mosaic, O for the official reports, N for which ones are normal, D, will they help me get my dreams or reach my dreams or fulfill my dreams, and the S is sex. No, I'm just kidding. I just thought I'd throw that in to see if you guys are awake. The S is for sperm on the day of the egg retrieval. I know it seems like basic stuff, but people just don't know out there what questions they should be asking their doctor. So that's why I do what I do. I come up with really fun mnemonics. I'm trying to sparkle here by reminding you guys about embryo diamonds. I just got these in the mail, so I thought it'd be fun to wear them for tonight, and they are not real diamonds. I don't wear real diamonds because if you guys don't know, I have a tendency to lose things. I have a bad sense of direction and I tend to lose things, but I do know where to put an embryo. Thank God I know where to put an embryo. I joke and I tell people that my parents, they name me Aimee, get it? A-I-M, Aimee, because I really have good aim. Dun-dun-dun, I know. You're here for the fertility facts. You didn't know that you're gonna be here for humor as well. So side note, as you guys are gathering around, waiting for me to start answering questions, I actually really kind of want to be a comedian, like for real, but people just tell me I'm not as funny as Amy Schumer. So I have written a comedy sketch up for myself to go like live, but then my sister said to me, she's like, Amy, someone could actually record it and then other people might see it. So I think for now, I'll just stick with my day job of helping anyone who needs my help become a parent. And then maybe when I'm like 85 and I probably won't remember who I am anymore, then I'll take my show on the road, so to speak. Okay, are you guys ready for the fertility questions? Here we go. Question 1. Thank you, Dr. Aimee, for doing what you're doing. We started trying over a year ago, got pregnant quickly, and I miscarried at 9 weeks. We haven't been able to get pregnant since and are starting medication for IUI next month. I'm 34, my husband is 37, and I don't like the unexplained diagnosis. The only slight abnormalities we have are a slightly arcuate uterus, factor V Leiden heterozygous, and a morphology of 3% when they want a minimum of 4, but the count and motility are high. I keep pushing for more testing and my doc has given me some normal karyotype, DNA frag, but I wonder if mild endometriosis is playing a factor because I have dull and sometimes pinching pain. I get it on my left ovary throughout my cycle. My doctor says even if I do have it, she doesn't want to do a laparoscopy, and it's likely not affecting my fertility because there's no sign of it on HSG on ultrasound, and my AMH is 2.7, FSH 9, 22 follicles, last day 3 ultrasound, my day 21 progesterone 17. His count just told me a little bit more about the sperm, and here are the questions. Do you think 3 rounds of IUI are a good start followed by IVF, or is Clomid and IUI a waste of time in this case? I greatly appreciate your innate desire to help women and families through the most difficult season of their lives. And there's no doubt about it. Being a fertility patient is no fun. I really want all my patients to be parents as soon as possible. So thank you for sending this very thoughtful question. And I think so many people had the same question. So basically what she's saying is that she's 34 years old, 37, has been given the diagnosis of unexplained, but it sounds like there's a lot of explanation here. When the morphology is low, that could point to a fertilization issue that IUI can't overcome. IUI is not the best treatment. I mean, I wish, you would think if you took a bazillion, and not bazillion, like who has bazillion sperm cells? If you took a bunch of sperm cells and put them right next to the egg, you would think that the sperm would know where to go, wouldn't you? I mean, you would, but they still don't, you guys. They just don't. So IUI pregnancy rates are not that amazing. They actually really suck. And I think that if you took like 5 fertility patients that show up for their first fertility appointment and you said, what do you think IUI pregnancy rates are? They'd probably be like 65%. And the reality is it's like 10 to 15%, right? I mean, like, that sucks. That's not very good. And so if there is a potential for a fertilization issue, like if the morphology is low, IUI may help, but IUI might not solve the problem. So you guys know my strategy, diagnosis before treatment. So it seems like there might be a fertilization issue here. The fertilization issue could be sperm driven, but it could also be related to the egg and sperm not seeing each other. Because if you have endometriosis, there might be some scar tissue inside the pelvis blocking the ability of an egg from even being able to get into the fallopian tube. And that might be a difficult situation. So listen to your ovaries. You probably hear people say, listen to your gut. But I'm always telling people, listen to your ovaries, like really listen to your body. And if your body is feeling like something is not right and you might have endometriosis, find the answers. You know, there are people out there that just don't want to go right to IVF. And there are people that want more information. And in the old days, I make it sound like I'm 100,000 years old. When I was in training, literally, you would come in, it was 2005, and you would come in for your new patient appointment, and we would literally talk about booking you for a laparoscopy procedure. And the reason why we did that so much back then is because IVF pregnancy rates weren't as excellent as they are today. So we tried our very best to help people get pregnant as naturally as possible without IVF. But nowadays, IVF pregnancy rates are so high, it's very natural and normal for doctors to be like, why would you want to do a laparoscopy? Everything looks fine. Let's just do IVF. But I totally get it, because if it were me in this woman's shoes, I would be asking and thinking about the same things. But this is the thing. Remember, the egg whisper golden rules. You have to ask yourself, how many kids do I want? How old am I at the time that I'm starting? And then say to yourself, will this treatment give me the opportunity to have the family size that I want, right? So if it's, I'm going to do IUI and you get pregnant, well, that's awesome, but you're starting at 34. You might be 36 with your next pregnancy. And it might be helpful to freeze eggs or embryos or both, depending on your situation and your belief system, so that by the time you're 36, you don't look back and be like, oh, why didn't I have this conversation with my fertility doctor? Why didn't I freeze eggs while I still had healthy eggs? So just remember those golden rules. And I think you're doing all the right things. You know, go to ballsmethod.com, literally. I don't know what I mean by literally. I don't know. That sounds weird. But for your husband's sperm, you just want to get them in tip-top shape. I want you guys to both live your best lives, be as healthy as possible, take your supplements, sleep well, drink water. You know what I'm talking about. So if you watch this show, you know I'm all about paying attention to sperm and egg health and not allowing anyone to sugarcoat sperm results and getting to the bottom of things. There should be a joke in there, but I can't figure out how to fit it in. But thank you for your question. Here's another question. Hi, Dr. Aimee. I'm 27 years old. I've been watching your show on YouTube, and thanks so much for all the information you put out. I have a question about miscarriage. So for those of you who don't know, you can catch all of these on YouTube. So youtube.com/Egg Whisper Show. I got pregnant, and unfortunately the pregnancy at 11 weeks was diagnosed as a miscarriage at 7 weeks. I'm sorry. 2 months later, I got pregnant. Everything looked okay, but then the pregnancy stopped growing at 16 weeks. Some tests were carried out, and the results said there were 2 areas of infarcts present in the placenta, and therefore there was no need for intervention. I got married a year ago, and my husband and I really want to have a baby. Please, doctor, is there anything I can do differently? And that's really hard, because as women, what are we going to do? We're always going to think that there's something that I can do. And so much of being pregnant is completely out of our control that I think it's really important to control the things that we can. So let's talk about my angel method. Literally just like it sounds, ANGEL, for anyone who's gone through even one miscarriage. It drives me like on a bonkers level of 0 to 10, 10 being the most bonkers that you could possibly drive me. It drives me bonkers when patients come in here after having had, let's say, 2 miscarriages, and they're told by a doctor, well, you just have to have a 3rd, and then we're going to do something to see if we can help you. That's just not how we treat women. It's not how we should treat people. And I imagine if a man ever had a miscarriage, in a heartbeat, there would be policies and procedures in place to make sure that no dollar was wasted figuring out what we could do. But when it comes to women, we're like, oh, honey, it's okay. It'll happen next time. Well, don't honey me, okay? So it's really important to go through the angel method to think through all the things that could potentially cause what's happening, so you are doing everything that's in your control, because that's so important to us, right? We all want to feel like we can make a difference, because at the end of the day, no matter what I tell my patients, they're still going to find some way to blame themselves, and I just don't want you to. So I think if you do a thorough and complete workup, there's a less likelihood or a lower chance that you're going to somehow think that you did something wrong. So the A stands for anatomy. So in a case like this, I want you to look for a uterine septum. See if you have, for example, bicornuate uterus. A uterine anomaly can sometimes cause the problems that you're describing. And another issue could potentially be adenomyosis. So that's a form of, for example, endometriosis or fibroids in the wall of the uterus. And I just mentioned the other word, fibroids. So look carefully at the anatomy. And then also think about your age and your AMH level. We know that women who have a lower egg count have a higher risk of having miscarriages because of aneuploidy or abnormalities in the chromosomes of the pregnancy. And then the other thing is autoimmune issues. So an autoimmune disease can sometimes cause these issues as well. So talk to your doctor about this stuff. And it's not confusing. Obviously it's confusing to go through something like this, but the workup is very straightforward and your doctor will know exactly what to order. And if your doctor doesn't know, there's another doctor that does know, because I'm not the only doctor out there that is very passionate about helping people with miscarriages. There's so many of us out there. Look at your nutrition, look at your genetics, you and the sperm source, look at the possibility of any endocrine issues like thyroid, diabetes, and look at your lifestyle, your body size, medications you're taking or potentially not taking that you should be taking, and then meet with a specialist, especially after 2 miscarriages. And there is still a really good chance, even after 2 of the most devastating experiences of your life, that you will go on to have a healthy pregnancy. And I hope that I'm right. And thank you for sending in your question. Here's our next question. I want to start by saying thank you for all the ways that you make your immense expertise available to not only your patients, but to everyone. Your commitment and time to put in to educate everyone through so many platforms and giving us all our best chances for healthy pregnancies is truly amazing and so much appreciated. I'm not sure when you're going to do another Q&A right now, but I have one question. Actually, my mom wrote that, you guys. It wasn't a real thing. I'm just kidding. This is a very sweet person. Thank you for saying that. Here's the question. I'm 32 years old. My husband and I have been trying to conceive for 2.5 years, with 1 miscarriage last year after using Clomid. We have been seeing a fertility doctor for 8 months now and tried 2 IUIs with no luck. I just did my first round of IVF. 19 eggs were retrieved, 14 mature, 7 fertilized through ICSI. Of these 7, 1 made it to the blast stage. It was graded 4BA and frozen. For the other 6 that did not become blastocysts, half did not make it past 4 cells. And there was a lot of fragmentation for all of them. Because we only have 1 good embryo, we decided to try another IVF cycle to hopefully get more embryos to freeze before doing a frozen embryo transfer. Do you have any advice for how to make this round more successful, or have any ideas as to why so few made it to the blastocyst stage? I was surprised by the low number of blastocysts since my AMH is 4.9, but I know that this is not a full picture of egg health. It is surprising, and when things like that happen, it's quite devastating, especially when you're told things from the beginning, like, oh, the average blast formation rate is 50% or 60%, and here you are at 10% or less. So it's normal to feel like, God, there's something really, really wrong with me. And what I tell patients is this: I celebrate that 1 blast that you have. And it is so great that you chose to do IVF when you chose to do it, because obviously it's going to take IVF to deal with the fertility issue that we're dealing with. And now we finally have an explanation for why it's been so hard to get pregnant and why the pregnancy that you did have miscarried. And it sounds like it's due to egg quality. Of course, it could be sperm quality too, you guys. You know me, I'm never going to blame eggs for everything. But look at egg health. Think about the supplements that you can take. Consider HGH priming, for example, adding HGH to your protocol. Make sure you've done enough genetic screening. Look at the chromosomes of both you and your husband to make sure we're not missing some sort of chromosome issue in either one of you. It's hard to know because you had one embryo that had reached the blastocyst stage and the rest didn't. So we just don't know if the rest just didn't have normal chromosomes or not because of something that you guys have inherited from your parents. And there's so many genes that are responsible for a blastocyst to continue to grow and progress. And if some people carry some variants, believe it or not, there was a company, and I wish that company was still around. We could actually test patients for these different variants that would cause their eggs to be potentially lower quality. So you would have that information, for example, before you froze your eggs or before you started IVF. Unfortunately, that test isn't available. I'm hoping it'll come back. But the answer is probably in your genes. And, if I had access to tests that I could do that would see if these genes were present in your body, God, I would love to do them. But at the end of the day, just because you had one cycle where you only had one embryo reach the blastocyst stage, it doesn't mean that every single cycle is going to be like that. To steal a quote from Forrest Gump, IVF is like a box of chocolates. You just don't know what you're going to get. And I'm probably going to totally screw up the quote until you bite into it. And so everything can look beautiful. You just have this beautiful box of chocolates. You open it up and you go in and you're just like, ugh. At the end, you're like, this was not what I expected from this box of chocolates. So don't give up. The fact that you have a beautiful blastocyst is a sign that you probably have more left. And I would just add that I would consider implantation testing to make sure we're not missing another reason to think that maybe you should do something, for example, treat endometriosis if maybe that's present. Because endometriosis can certainly affect our egg quality and cause the same issues in your eggs that you described as well. So I hope this answer helped you. Okay, here is another question. Let's see here. I just started listening to your podcast. Why, thank you. I recently went through 2 failed IVF cycles with similar results. First cycle, 19 eggs, 10 mature, 3 fertilized, and no blasts. Oh, I'm sorry. Second cycle, 10 eggs, 5 mature, 3 fertilized, and no blasts. I'm sorry. And I'm trying to figure out if it's worth trying again. Obviously, this woman is the definition of resilient. She's tough. She's making a plan. She's inhaling and exhaling. She's 32 years old, 32, with an AMH of 0.9. She already has 2 kids. You guys, don't hate her. But there are people out there that the pain of not being able to have another child even after 2 children is just as much as the pain of not being able to have one. So don't hate her. I got pregnant with each on the first try. However, after the delivery of my second son, I had a massive postpartum hemorrhage, which resulted in DIC and me losing almost all of my blood, and they removed my uterus. Initially, my doctor said he would assume my AMH is low because of the blood loss, but he expected my eggs to be healthy since I'm relatively young. However, after the last cycle, he basically said to give up and that my eggs were poor quality. And I'm really frustrated because the expectations he gave me initially were that my eggs would be in good shape and that my hemorrhage would not have affected the quality. But now he's saying the opposite. What is your opinion on this? Are there any other factors that could be affecting my egg quality and preventing them from fertilization and blasts? Okay, so let's talk about sperm here, okay? What about sperm? Is sperm the reason why these embryos aren't progressing? So think about the Balls method. Think about doing sperm DNA fragmentation testing. If this is a new husband, new sperm source, new partner, and he's not the father of your first 2 children, let's look into that. Look at his chromosome analysis and see and make sure that we're not missing anything big picture that could cause the issues that you're describing. Is it possibly egg quality? Yeah, it could be. Embryo quality has a lot to do with our age, genetics, and environment. At your age and your AMH, given the fact that you have a 1-year-old, I'm going to say that you still have a good egg left. Do I have that crystal ball? No, I don't. But clinically, I really feel like you probably should find a doctor, and there's so many of us out there that are going to believe in your fertility. I have seen patients and I have taken care of them, and I have personally had cycles just like the ones you describe. I know they're not my fault, but I get more fired up every time that happens. And I'm like, well, I'll be damned. Just means I have to work even harder. And we talk about What are we going to do if the next cycle doesn't work? What other protocol can we use? Should we consider this supplement, that supplement, and a different approach? So talk to your doctor about that. Talk to your doctor about different protocols, maybe different procedures with the sperm that could potentially help, supplements for both you and your husband. Maybe he should see a urologist so you're not missing something that could potentially help you guys down the road. There was a very good interview that I did with Dr. Blake Evans. You guys, if you haven't watched it, we talked about aspirating sperm from testicles for guys, and I hope no guys watching this, because you'll probably faint at the thought of doing that, because that's what guys do. Just kidding. That's a very big generalization. Please don't be offended. But when it comes to the lack of blast progression, one of the things that his study found is that if you aspirated sperm from the testicle, they actually got a higher number of blastocysts and a much higher live birth rate. So take a look at that study, talk to your doctor about the things that I just brought up, and see what happens. And of course, reach out to us again, because I'm sure everyone watching here is going to want to know what happens, and we'll follow up. We'll give everyone a follow-up. Okay, here's another question. Thank you so much for all you do. I want to know more about Anti-Inflammatory Protocol. Honestly, I have to say you're making a huge difference in people's lives, and I thank you so much. I pray that God blesses you with the good, all the good your heart desires. And the only thing that I want in my life is for the pain and suffering that goes along with fertility challenges to go away for anybody that's listening, anyone that's watching, and anyone that's reading. That's my only goal. That's it. That's it. It's really as simple as that. Okay, so as far as anti-inflammatory protocol. So first of all, a plant-based diet. Second of all, being as lean and mean as you can. Third, meditation and yoga. I know I'm not talking about medications yet. As far as medications go, there are some folks out there that are really smart, and they're not medical doctors, but they're naturopaths, and they're also functional medicine doctors out there, and they also have MDs, and they're functional medicine naturopaths as well. And I bring this up because I'm not going to be the expert on everything, and I learn a lot from other people, and I sometimes refer my patients to other people, and I learn a lot from them about the approaches that they use. And one of the things that might help in some cases, not all, is adding, for example, low dose naltrexone or even higher dose naltrexone, depending on your situation. So that's something that I've been using more in the last 6 months, and I've seen some pretty remarkable results. And I'm not going to summarize or make recommendations of all my results quite yet, because I feel like I need to have a little bit more experience under my belt before I can tell people that this could potentially be something that can help. As far as other things, not necessarily anti-inflammatory, but there are antihistamine protocols that I've used for patients who have, for example, had recurrent implantation issues. I hate the word failure, because if you're labeled as failure, you're sometimes meant to think that it's never going to happen. So we'll just talk about it as issues. So people who have recurrent implantation issues sometimes can benefit from Claritin, Pepsid as part of their protocol to potentially improve implantation rates. That's something that I have seen. So those are the kinds of things that I do when I'm thinking of anti-inflammatory. And for the person who sent me this question, please email me again, because I have a list of supplements and protein shakes that I send to my patients that they can order and take as they're preparing for their embryo transfer. Especially if you have endometriosis, these things can sometimes also be extremely helpful. Okay, here we go. Next question. And I think I changed my page too fast. So let's see here. Here we go. Hi, Dr. Aimee. I need your help. I've had 3 failed transfers. First one ended at 6 weeks due to a blighted ovum. The second and third were negative. I started bleeding on the 7th day after transfer. The second and third were done a month after each other. All 3 transfers were unmedicated, as my doctor thinks I'm a good candidate for that. My history is I have a history of infected fallopian tubes. I've done 3 laparoscopy surgeries before I even started IVF. My fallopian tubes are completely removed, and after I was placed on antibiotics for 6 months to treat the TB, that is when we started IVF. I've done only one IVF stimulation, which yielded 7 PGT embryos. Wow, 7. Sounds like 7 normals. I'm 27. My lining is always great before the transfer, over 8. My question is, what is wrong? I've cried my eyes out. I don't know. What can we do different for the 4th transfer? I have a patient right now, today. I did her ultrasound, 4th transfer. First transfer was a miscarriage, just a blighted ovum, which means it's a sac that didn't have a fetal pole or yolk sac. 2nd transfer, negative pregnancy test. 3rd transfer, negative pregnancy test. 4th transfer, twins. It's incredible. I mean, I wish I knew what the difference was between the 4th and the 1st transfer that made the difference. This woman was also young with a very healthy egg count. Similar reason for doing IVF, but I have had these experiences as well with my patients. And I wish I had a piece of paper that could say why this happened and what the difference was between the 4th transfer and the 1st. And the thing is this, I have every reason to think that you should still be successful, and you'll be successful with your 4th, but I'll share some of the things that I've done for my patients in a similar situation. So number 1, I won't go through the angel method or workup because I already did at the beginning of this Ask the Egg Whisperer, and I know you guys know all the angel things that you need to be asking about, but that's one of the things. Ask your doctor if you're getting enough progesterone and if you're a candidate for a blood thinner like Lovenox. The other thing is just thinking a little bit outside of the box, and I know if I had 5 IVF doctors in front of me, probably 4 will roll their eyes, and that's okay, I'm used to it. 4 will roll their eyes when I bring up something like intralipid infusions. And the thing is this, that sometimes when things don't work and they don't work again and they don't work again, and you're just like, I'll just add this and we'll see what happens. I don't think in the patient's case that I just shared with you, the intralipid infusions is what made the difference, but it's something that we did different. And, as far as intralipid infusion, it's just like going to Jamba Juice and getting a protein shake, but instead you're sitting in an IV pole and getting it put through your IV. Except it's a little bit more expensive, maybe like 100 times more expensive than a Jamba Juice. But, it's considered controversial because the studies, basically if you can find a study, I don't know if you guys know this, that says anything you want nowadays, it seems. But the most robust studies on this topic show that it may not be helpful, but I know anecdotally for me, I've seen that it's helpful in some cases. So those are the kinds of things that I think about as to what you could potentially do differently. And you guys all know about the Egg Whisperer diet, the diagnosis, IVF, embryo transfer planning, and that can include endometrial testing, and then your embryo transfer, or what I call T-Day, right? Transfer day, or your baby's birthday. So, kind of pre-birthday. And I love it when my patients reach out to me, like on the 1-year anniversary of their transfers, and they send me a picture of the embryo on the transfer day and then the baby a year later. And the baby's usually obviously like, what does it be? A little over a year. It's really cute. I can't do the math right now. End of the day, guys. But my point is, and I'm totally digressing, that remember what your diagnosis is. It's tubal factor because of inflammation in the fallopian tubes. So make sure you're addressing it with the protocol that you're using for the transfer. And in a case like yours, I would definitely recommend doing endometrial testing, like the ERA test and the Receptiva test. I do them together if you guys haven't done that yet. Okay, so thank you. Okay, guys, here is another question. Let's see here. Hi, Dr. Aimee. Getting pregnant really sucks, and it's been really hard for us. I have a husband who is supportive with everything else in my life, but when it comes to trying to conceive, it doesn't seem like we're really connecting. We're not connecting on the journey, and he feels like since the problem isn't his, he doesn't really feel like he needs to participate that much. So when I tell him that it's time to have sex because I'm ovulating, he's really not that into it. We potentially have sex like the day before ovulation, and then after that, he won't have sex with me. You guys, what would you do? I wish I had a live audience. Come on, somebody, get me a live audience. Oprah, find me. Don't worry, guys, Oprah's not calling me anytime soon. That'd be kind of fun if I had a live audience and I would see what you guys would do in this situation. So I'll tell you what I would say is, let's talk. Let's have a group session, and then let's just really, really figure out what's going on. Guys are very emotional too. And I know I make fun of sperm, not all the time, but just sometimes I make funny jokes, or at least jokes that I think are funny. But guys are scared just like we are. They definitely want to please, and they're scared of being failures. So it's amazing and wonderful that he's supportive in all the other areas of your life. But it's kind of heartbreaking to me to hear that he's not supportive and part of your journey because he doesn't feel like it's his fault. So let me tell you this, when you guys have kids, it's not going to get easier. And if he has that type of temperament and personality, you have to ask yourself, if you're in a situation with your child and then he checks out because he doesn't feel like it's his fault, you might be kind of annoyed. And the annoying, what is it, on an annoying scale of 1 to 10, it might get to be a 10, where now you're dealing with custody issues because you've had enough and now you're dealing with a divorce. That kind of stuff is annoying to me. I want you to figure this stuff out now. I want you to go to therapy. I definitely want to give him the benefit of the doubt and think that he's a good dude. But good dudes don't check out and say, it's not my fault, so I'm not going to have sex with you. Good dudes would be like, my husband, what can I do for you? How can I help? I was joking with my husband. This is actually a true story. I said to him, and he's like amazing and awesome. I said to him, honey, because you guys can see my hair and like how not fabulous it is, but I'm just not going to complain because like who would complain about their hair right now? Because so many other things are going on in the world. And I said to him, I said, wouldn't it be awesome if like you could flat iron and blow out my hair for me, and like I could teach you how to do it. We can watch a YouTube show and I just sit in the bathroom and you would like blow out my hair. And he's like, okay, I'll learn. I mean, like that is a good dude. Like you want the dude to be like, yeah, we'll have sex. You just tell me and I will be there. But I know it's stressful. So get to therapy, do online stuff, not like kinky stuff, but maybe add in some kinky stuff. Group therapy, one-on-one, and let's get to the bottom of it before you guys have a baby. Because I can tell you, you're going to be really annoyed with him if he pulls that shit when you guys are pregnant and then have kids. Trust me. Okay, here's another question. I'm just noticing my makeup is running a little bit. Okay, I'm 43 years old and I've been trying to have a baby through IVF since October of 2019. In August of 2019, I had an abdominal myomectomy to remove fibroids. I had my first IVF retrieval in February of 2020, 10 follicles, 6 eggs, 3 mature, 2 embryos, with a day 6 blast times 2, an AA and an AB. I did not have PGS testing done. My HSG exam showed, for those of you who don't know what HSG is, stands for hysterosalpingogram, that's a tube test, no blockage or any other problems with my fallopian tubes, but there was fluid in the uterine lining at the time of my exam. So what she's asking us is about fluid in the lining. The meds taken for transfer have been estrogen 3 times a day vaginally and 1 milliliter progesterone and oil daily. My problem is this. I've had 3 cycles and I haven't been able to transfer once because I keep getting fluid in my lining. I've had a total of 4 fluid aspirations done while on the estrase and progesterone and oil, and every time the fluid returns. I'm so annoyed. What would you recommend? I get pretty annoyed too, and I've had this happen before. And when someone's had a myomectomy, I always wonder if there's a pocket of scar tissue inside the cavity. Even though you can't see it on the HSG, it is very wise to consider doing a hysteroscopy. And I know this sounds weird, but sometimes just flushing all that fluid through, because when you use a hysteroscope, it's just like a camera, and then it just pushes fluid out, and then you can, basically aspirate it all out. By doing that, you might be removing whatever is causing that fluid to accumulate. The other thing that I would recommend is not using estrase, because it seems like your body really likes it and you're making a ton of egg white cervical mucus because of it. So potentially consider other approaches to getting your lining thicker, like a natural cycle approach. Trying Femera maybe for 5 days and then coming in early for an early ultrasound, maybe around like cycle day 8 through 10, and see what is going on with your lining. And if your lining is not doing what it was doing before, you're good. If your lining is still accumulating fluid, well, I would say rethink doing a transfer. And this is the thing, you're 43 years old, your embryos are like so precious. I know you didn't do PGT, and that's okay. But if you were a patient of mine at 43 and you were having these issues with fluid in your lining, we were waiting and waiting and waiting, and it sounds like you've been waiting several months to transfer, I would say, I wonder if it makes sense for us to do another cycle now and collect more embryos while we still have eggs, because what if we look back and kick ourselves for not thinking about that first? So maybe consider that. and really look very closely at your uterus. Like I said, with a hysteroscopy, maybe consider another HSG and look really carefully at the fallopian tubes, especially if that last HSG was over 6 months ago, to make sure that there isn't a hydrosalpinx. And you guys know my style, always request official reports. If you can't see it, you don't believe it. Request the official report, read through it with your doctor, put it in your binder, and you know the binder, it's the Tushy binder, T is for tubes. Get everything labeled and make sure you're sitting down with your doctor and asking them all the right questions to see what they can do to guide you. And then always get a second opinion. It's not a bad idea to talk to someone else, maybe even in the same practice, or ask your doctor. I have patients that do this with me. They're saying to me, Aimee, I know you can't tell me this, but what would you do if it were me? And I'm like, huh? Like, why can't I tell you what I would do if it were me? Like, that's what I do. Like, I know a ton about one thing only, and that is fertility. And of course, I'm going to tell my patients, like, this is what I would do, knowing what I know about your situation. And it usually is what I would do if it were me. And if you chose, let's say, not to do another IVF cycle and your uterus was still accumulating fluid, I would consider talking through more creative family building options, like talking about surrogacy. And ideally, you carry your own pregnancy, but there's obviously a reason why your uterus is telling you this story right now and saying, I have, fluid accumulation. And sometimes that can potentially be a cause for a failed implantation or for abnormal placentation. So that's a placenta that doesn't implant normally. Okay, so I'm going to go to the next question now. That was a great one. Okay, hello. Hi. I've been visiting a fertility doctor now for a bit over a year, and a lot has happened. I want to have a baby. I love my doctor and the staff, but it just always feels like we're hitting a wall at all times. My last appointment, the doctor asked me to lose weight and to get my BMI inside a good range. And the one thing I struggle with my whole life is holding me back from having a baby. I wonder if the weight is a big factor for IVF. I'm 5'5", 263, healthy, no high blood pressure, no conditions. Please advise. I feel like I'm running out of time. So when I got this question, I asked her, what's your AMH? And her AMH was really great. Her fertility issue is tubal factors, so her fallopian tubes are blocked. I'm just going to take a little sip of my yummy coffee here. So with blocked fallopian tubes, IVF is what she needs to get pregnant. And the thing is that, I don't want anyone to fertility shame, or I should say not fertility shame, but body shame anybody. So the reality is that when your BMI is, let's say, over 30, it's kind of controversial. And your elevated BMI might decrease your implantation rates. We know that it can increase your risk of preterm labor, preterm delivery, and having a baby with autism, and then preeclampsia, which can also cause preterm labor and preterm delivery. But I think from an IVF standpoint, it makes it harder to access the eggs, and the medication requirement that you'll have during the cycle would potentially be much higher than someone with a lower BMI. So you would save yourself money, I guess, by doing what you can to lower your BMI. But going through the process of being a fertility patient is depressing. It's very common. I mean, I tell my patients, if you don't gain 20 pounds while you're going through IVF, it's kind of like you lost weight. And it's true. I mean, you're pumped full of hormones, your metabolism changes, how you see food changes, how you see everything changes. So to tell somebody you need to lose weight before you go through IVF, that's just a really hard thing to hear, especially after you've been a patient at a clinic for over a year. You guys, that rhymed. I don't know if anyone caught that, but that was like poetry right there. So my advice for you is this: build your fertility team. Build a group of people around you that believe in you, believe in your fertility. I don't think there's anything wrong with your body size. I think making embryos, especially because you have a high AMH, would be a great thing to do right now, and then see how you feel after you go through the IVF process. Because suddenly you might transform. You might be the butterfly that I see you as, and then you will fly and you will take care of yourself and you will get into the best shape of your life. It's one thing for me to tell a patient, imagine your IVF cycles like a marathon and go run every day and just be as fit as possible. If I told people that, well, I do actually tell people that sometimes, they roll their eyes at me because it's like, really? Like, I'm like in the worst spot of my life. I'm super depressed and you want me to like go out and run every day? No. So that's why it's important to have people around you that believe in you. Find a therapist that you can talk to, friends that will support you, a doctor that will do the same, and someone that will take care of you and take you through IVF. At your body size, you would be a candidate for IVF in many centers. And so you just want to ask the question as to what their requirements are and just get it done. Get it done, get your embryos frozen, and then ask yourself the question, how should I best prepare for my transfer to give me the best chance of pregnancy? Because it isn't until you see yourself thinking, the reality hasn't set in that you're going to be, I know you believe that you're going to be a mom because obviously if you didn't, you wouldn't reach out to me. I truly believe that you're going to be a mom, but I find that once you have your embryos, you're like, oh shit, it is happening. And I now realize that I want to have the healthiest pregnancy possible. And I'm going to do every damn thing that I can do to give myself the best chance. And yes, I did say a bad word. And if you're a patient of mine, you know that sometimes that comes out because this is really heavy stuff. And it's not all rainbows and lollipops around here because that's life. Okay, next question. This is a great one. Do you recommend Zymote? I don't know if it's Zymot or Zymote, and Pixie to patients with a normal semen analysis but failed IVF cycles. Have you seen it help? And my answer is, you guys know me, I typically do DNA fragmentation testing, like for everybody almost, it seems. DNA fragmentation testing can be done without a doctor's order, and you can get a result back, and it can guide you as far as whether you need more advanced technologies during your IVF cycle like ICSI, Pixie, and Zymote. And so certainly, yes, I do Pixie on 99.5% of my patients, just so I feel like I've done everything possible to give my patients the best chance of pregnancy. And I know not every lab does it. I know a lot of doctors have beliefs as to what works for their patients and what doesn't. And I think it's really important to listen to your doctor and, you know, do what they feel comfortable with and not, like, for example, introduce a new technology. But the labs around here are used to, and when I say around here, for those of you guys who don't know where I am in the San Francisco Bay Area, and I have access to the best labs, I'm kind of biased, in the world. And when there's a new technology out there, you can believe that they will be the first ones to have it, the first ones to train people on it, and the first ones to have live births from it. And I think I might have the first live birth in maybe Northern California or California using Zymote, and this was a couple years ago, and I did Zymote with Pixie as well for them. So her next question is this: what are my chances of pregnancy, excuse me, with my 2 day 7 embryos graded 6AA and 5AB? And I would say that's a really good question to ask the lab. Ask them, you know, for me, I would say, what time of day did you have your egg retrieval? I do my egg retrievals crack of dawn. Like, this is the face of someone who woke up at 5 this morning and did an egg retrieval at 6 a.m. I know, hard to believe because I look so put together. But there are a lot of centers who do egg retrievals like at 3 p.m. and 4 p.m. So if you think about it, a day 7 embryo is actually closer to a day 6 embryo for me. So I don't know that I would worry too much that it's a day 7, but asking your IVF doctor exactly what the statistics are for them is important. Day 7 transfer rates or implantation rates and live birth rates are a lot lower than day 5 and day 6, but there certainly have been so many healthy pregnancies all over the country and world, and that's why we culture embryos to day 7. Because again, you guys know me well, you want to ask yourself, should I do another cycle to get myself more embryos before I transfer these so that I don't look back in 2 years and wish I had? So while you still have your healthy eggs, and it sounds like you make beautiful embryos, they just got there by day 7, see if it makes sense for you to do another cycle first. So here's another great question. Do supplements help stop further aging of eggs, or can they also rectify existing problems with egg quality? And I would say if we were mice, they would actually do both. And I think that over time, we're going to learn more about the human experience with CoQ10. And I do think that in some people, and I'm sure there's a specific genotype, meaning you have genetic, you have the genes that would potentially respond to CoQ10, and there are other people that don't, that the CoQ10 just doesn't work for them. And so we know CoQ10 levels start to go down in our body around age 30 or so. And as our CoQ10 levels go down, the number of embryo chromosomal abnormalities rises. So that's one of the reasons why if you are a patient of mine, even if you're 19 years old, calling me to talk about your fertility and egg freezing, I'm going to say, take CoQ10, and then take CoQ10, and then take CoQ10 again. And stop CoQ10 when you're done with your babies, but at the same time, it's also an anti-aging supplement. So it can't hurt to take it for other reasons like cardiac health, and there are a bunch of reasons, I'm sure, aside from just fertility, that CoQ10 could be helpful for. But for us and for women, people often ask me, like, how long should I be on it before I start IVF? And I think the answer could be 10 years, right? It could be 6 years. And that's not fair to not share these secrets with women everywhere. So I feel like, CoQ10 should be in our water. Of course, I'm biased. There are a lot of things that should be in our water, and CoQ10 should definitely be one of them. Okay, here is another great question. You guys, this is a long one. I'm going to see how I can summarize it. Let's see. I don't know that I can. This one's very, very long. I'm actually going to set this one aside, and it's about 5 pages long, and I really want to give it the time that it needs. So I'm going to set this one aside, and I promise that I will make this the first question that I go through on the next Egg Whisperers show next week. You have my word, okay? It's going to be the first thing that I go through. Okay, here's our next question. Your show's incredible, and the knowledge you share is both helpful and uplifting. Well, thank you. Okay, here we go. I'm 32 years old. I was diagnosed with unexplained infertility. Eye roll, please. Yes. My husband and I have been trying to conceive for 1.5 years, and I've had 2 chemical pregnancies along the way. All diagnostic tests were deemed normal per our doctor. After 1 natural cycle, IUI no monitoring, our RE, reproductive endocrinologist, feels like I do not need any monitoring during my upcoming IUI Clomid cycles. I was told I responded well to the initial IUI Clomid cycle. I'm now only using OPKs to determine the IUI timing. Is this enough monitoring during IUIs? Oh, that's annoying. Let me tell you. And there's no sugarcoating here. I mean, if you want monitoring, get monitored. If you don't want monitoring, don't do it. And there's a reason why we bring patients in every cycle to look at their follicles and their lining, especially when you're taking Clomid. First of all, if you know me, Clomid is Clomonster. It causes you to require an exorcism at the end of your Clomid. But my point is that there are variations in how we respond, the number of follicles, and Clomid can also thin out the lining and be an anti-fertility medication. So I would highly recommend thinking through, number 1, what are the potential reasons for your fertility issues? So don't accept the diagnosis of unexplained. When someone tells you that, I would just say, thank you for that. What are my possible explanations? What could possibly going on for a 32-year-old with an AMH of 1.29 who's had 2 chemical pregnancies along the way, right? So number 1, angel approach or angel method. So think about your age. And I know it sounds crazy to think a 32-year-old could have egg quality issues, but if you guys have listened to this show, you know that there are many women in their late 20s and early 30s have reached out and shared what they've gone through. And just because your age is young and your AMH is good, it doesn't necessarily mean that you don't have egg quality issues. What you could be going through could be due to genetics, sperm DNA fragmentation issues, or a chromosome abnormality in both you and your husband, especially if you guys had 2 biochemical pregnancies. Be sure you ask for a workup. Look at the possibility for autoimmune issues, and look at the fallopian tubes. A lot of times recurrent biochemical pregnancies could actually be recurrent ectopic pregnancies, and people sometimes forget that. And so looking at the cavity, making sure there isn't a septum or a hydrosalpinx would be really, really important. And get more information. What could be going on could be anatomic. It could be related to, for example, endometriosis. It could be egg quality, and it could certainly be sperm quality. And then what you would do is go through the possible explanations and then ask your doctor, what can I do that's in my control to give myself the best outcome based on the possible issues and with the fact that I want, and then tell them, insert here, the number of kids that I want. Is the plan that you have me on going to help me reach my goals? Because I can tell you, if you've been trying for 1.5 years at 32 years old and you've had 2 biochemical pregnancies with an AMH of 1.29, I would want you to freeze eggs for sure, or embryos, or both, so that in 2 years, and we all know that it's a fertility myth, that if you get pregnant, the next pregnancy will be easy. It's not easy the second time around. For some people it is, and they shout it at the top of their lungs, and it's awesome for them. But for almost everyone else, it actually is harder to get pregnant as we get older. And certainly I want everyone to get pregnant naturally and without my help after they've used my help for the first baby. And I have really fun stories to share about that, but not on this show because that's called fertility bragging, and I'm not going to do that about stuff like that. But my point is that I want you to preserve your fertility so you can secure future options for yourself. So I think that would be an important thing to do. And you guys know what I'm going to say next. Take CoQ10. Okay, here's another question. Hello, Dr. Aimee. I'm 38 years old. I've had 4 IUIs and 4 IUIs and 1 miscarriage. I did IVF in June, 10 eggs retrieved, 9 fertilized. On day 5, all embryos stopped growing. My doctor told me I have low egg quality. What is your advice? So at 38 years old, having gone through 1 IVF cycle to have 9 fertilized eggs and no blastocysts, unfortunately, is not uncommon. It's not uncommon because when we get older, and I know it sounds nuts for me to say older to someone who's 38 because you're like young for sure, like there's no doubt about it. But from a reproductive biology standpoint, 38 is considered a situation where, and I didn't mean to use that word situation, where you have to be prepared for the possibility that you may not have normal embryos at that point in your life. And you have to say, I'm going to control what I can and surrender the rest and just do the work of doing what I need to have the family that I want and deserve. And just having had 1 IVF cycle that resulted in no blastocysts at 38 doesn't mean that your future cycles will be like that. The way I think about it, and again, I have had these experiences with my patients too, so I know what I've done differently to help them as far as different protocols, different supplements, making sure the sperm health is in tip-top condition. And I always ask the question, what would we do if this next cycle didn't work? It's a good exercise to go through because it allows you to inhale and exhale and know that there's always going to be an option for you to be a parent if that's something that you want. And sometimes we bring up things like creative family building to see how we feel about it. And I have had patients that say, God, why would I put myself through another cycle when I could, let's say, consider donor egg? Or I love the idea of using donated embryos, and tell me about that. So I think, for me, my general rule is I don't like to bring things up like that unless I can sense that a patient is open to it. And the way I bring it up is I say this, I say, because we had this experience so far, I'm certainly going to do everything that I can to give you a better chance of pregnancy, understanding that it's not in my control. I can only work with the DNA that I'm dealt. And if the same thing happens again, I would like to talk through what would we do differently after that cycle. What would you consider? And then I start that conversation based on the feelings that I'm getting from my patient. So if you have a doctor that's not bringing that up, guess what? You're going to say that. You're going to say, hi, doctor. I would like to schedule my post-IVF consult. I want to go through the details of my cycle and remember the diamonds, talk about the diamonds, talk about your embryos, get the official reports, and sit down and say, what did we learn from this cycle? What are we going to do differently? And what are we going to do if this next cycle doesn't work? And that is the definition of each and every one of you that's sparkling out there and watching this show right now, because you define resilience. And that's what resilience is. Every single person that's sending me a question is resilient. And the person who sent this is resilient, and that's what she's going to do. She's going to ask her doctor the exact questions that we just brought up right now. And same for you guys out there, okay? Here's another great question. Hello, Dr. A. Hope you're having a great day. I have a question for you. I'm 38 years old, South Asian descent. I had 2 spontaneous pregnancies this year. Unfortunately, 1 was a blighted ovum and 1 miscarried at 10 weeks. We got the fetus tested and it was a chromosomally normal female. Ugh. We did all the tests after that and found the following. TSH 4.8. So for you guys who don't know, that's a little bit high in the TSH. AMH 0.8. FSH 11, we did an IVF antagonist protocol and stimulation for 14 days, triggered with HCG, retrieved 11 eggs, 10 mature, 9 fertilized, but no blastocysts. What should be my next steps? And I appreciate your feedback. Oh, God, I'm sorry. There's nothing worse than going through IVF, having it not work, except going through IVF and having it work and then miscarrying. It's frustrating, and I've had those experiences. There really isn't an IVF experience that I haven't had so far, and I think the important thing of genetic testing of embryos is to realize that it's not everything. There are other things that need to be in place in order for an embryo to continue to stick and grow. But in a case like this, obviously, step 1, what we need to do is create more embryos for you. Step 2, very careful transfer planning. And what I mean by that is obviously you're going to do all the things that I talk through in my angel approach or angel method. But at the same time, you're going to think through the Egg Whisperer diet, reminding yourself, what is the diagnosis that I'm dealing with? Design an IVF protocol based on that diagnosis and do endometrial testing. See if your BCL6 level is high. Consider other protocols for transfer. And at the end of the day, when it comes to the T, which is T-Day, if you only have one genetically normal embryo that you've created, because I know you've worked so hard for your embryos, if there's only one that you have, given the fact that you've had 2 miscarriages, I would strongly suggest you think through more creative options like surrogacy. Because my goal for all my patients is for them to have all their options available to them to think through before they make a decision that's irreversible. So transferring your last embryo that's genetically normal, for example, if you do go through another cycle and having it miscarry and then having someone say, let's say 6 months down the road, have you ever thought of a surrogate? That seems a little too late. So I think thinking through it and then talking through what you guys know I'm going to say next. Doctor, what would we do if I did this next IVF cycle and it didn't work? And think about the answer there, because sometimes the things that you would do if this next cycle didn't work would be the things that you would do now without waiting. Okay, remember the slogan. I want you guys to be parents, not my patients, as soon as possible. Okay, here's another great question, especially because she started off with love your live chat. I'm 37 years old, Tushy checked. For those of you guys who don't know what the Tushy method is or what the Tushy check is, go to tushymethod.com, and my next Tushy class is this Monday at 4 p.m. Go to eggwhispererschool.com to sign up. Okay, just a little plug there. My AMH is 6.19. Holy smokes, that's awesome. We did 2 medicated cycles on letrozole with a trigger shot, but weren't successful. And my doctor said that since I ovulate monthly, confirmed by OPK, that medicated cycles won't work unless we do IUI. Is this correct? Also recently did an IUI with only 1 follicle, with increasing the dose of letrozole to 3 tabs per day versus 2 tabs increased chances of ovulating more follicles. On the previous medicated cycles, I ovulated 2 follicles each time. So you guys, listen to this. Her doctor said that medicated cycles would only work if you did IUI. Does that make sense? It would make sense if, for example, the only way you could get sperm inside the uterus is through IUI. So for people who have severe pelvic anxiety is what I call it. But otherwise, IUI is not necessarily going to be the only thing that makes a medicated cycle work. However, when you started off your question to me, not the part about saying how you love my chat, and thank you for that, but when you start off with saying, I'm 37. So Egg Whisperer Golden Rule number 9, I'm just kidding, I should definitely number them. Egg Whisperer Golden Rule number 9 tells me that we should consider doing IVF sooner than later, at least talk through it, and maybe be more aggressive with your stimulation so you can ovulate more than 2 eggs. So that if you can ovulate more than 2 eggs, that might give you a higher chance of pregnancy because each egg will have a certain percentage chance of being genetically normal. So the more eggs you ovulate, the higher the chance that you will have a normal embryo implant in your uterus. Think through the number of kids that you want, and then talk to your doctor about, just like you said, being more aggressive with the femera. And then if IUI is something you would like to consider, I would definitely consider it. And I would say that, you guys know me well to know that I always tell patients to have sex leading up to the IUI. And of course, listen to your doctor's advice. And then when you come in for your follicle check, I'll guide you further as to when to have sex from there. So I hope that helps. And you guys know to take CoQ10. Thank you for being such an amazing fertility resource. Your show is amazing and provides so much hope. My question is this: I'll be 32 in 1 month, and my husband and I have been doing ovulation induction and trigger shot and timed intercourse for 6 months. I have lean PCOS and suspected endometriosis, and I've never had a positive pregnancy test in my life. I don't ovulate without medication, and my husband's sperm is awesome. Long story short, my doctor is recommending laparoscopic surgery, and if this this fall to confirm endometriosis and to remove as much as possible, then to do letrozole, trigger shot, timed intercourse for another 6 months. What would you recommend? Is it likely surgery will significantly increase our chances? Should we continue the same protocol? This month I had 2 mature follicles, 23 millimeter and 19 millimeters, and a 10 millimeter lining at my mid-cycle scan, but even with similar good results, every month we haven't had any luck. And we're both getting very frustrated in the bedroom. Okay, so this is the thing. You're 32 years old, and it sounds like you might have a high chance of having endometriosis. Your doctor is so suspicious of it that they're recommending a laparoscopy. Endometriosis is horrible for our eggs, like horrible, horrible, horrible. It can affect our egg quality. It can make us run out of eggs faster. So if you're thinking that endometriosis might be the issue, you guys, endometriosis is a fertility threatening condition. I would consider freezing embryos. We talk about freezing eggs all the time. Get your eggs frozen, by the time you're 32. Well, in someone who's partnered and you've met someone and you're with someone, or even if you're not and you want to have babies and you're 32 years old dealing with this, I would say you're a great candidate of freezing your eggs, freezing embryos, or doing both now. Could you wait until after you did your laparoscopy surgery just to understand a little bit more about what's going on? Absolutely. Let's go back to the basics, the 5 steps that you can do to get your fertility checked: the T, tubes, U, uterus, S, sperm, H, hormones, Y, your genetics. So go to tushymethod.com and make sure you've done all of those tests. And if you guys who are watching right now are curious and want to take my Tushy class, 4 p.m. on Monday. Yes, I know it's Labor Day, but I still want to do the class. I still have space available. And we'll talk about these tests and then how you can use the test to get to a fertility diagnosis. And in your case, you want to ask your doctor, are there any other possible explanations for why I'm having a hard time getting pregnant? And if it seems like it's endometriosis, then I do think that it makes sense to consider embryo freezing for you and consider taking CoQ10. And the other endometriosis supplements that I recommend include N-acetylcysteine, a really good prenatal fish oil. It makes sure your vitamin D is normal, and not like me, I don't work out at all, you can tell, but do take really good care of your body and lift weights. So that's a little tip that I have for people who think that they might have endometriosis, is try and decrease the amount of estrogen in your body. We know that fat cells get converted to estrogen, and estrogen feeds endometriosis. So start lifting weights, talk to your doctor about the possible explanations, and if endometriosis is an issue, think about freezing eggs, embryos, or both. So I'm glad you shared your story with us. And I do think that your ovarian response is awesome. And it sounds like you're someone who could definitely get pregnant, not definitely, but it sounds like you're someone who has a really good chance of getting pregnant naturally and with IUI. So you can certainly try a couple more cycles. But I would say if you guys got pregnant naturally, as soon as you deliver, consider doing something to preserve your fertility so that if it is endometriosis, we know that it can get worse over time. Okay. Next question. And then to address the PCOS part, PCOS could also be part of our issue. Even if you have lean PCOS, you can have a high testosterone level. So I would definitely check all your PCOS labs again and see if you're a candidate for medications and supplements that can reduce PCOS. Okay, next question. I'm 28 years old. I have irregular periods. My BMI is 17. My AMH is very, very high, 21. Wow, that's high. I'm trying to conceive. I'm on my first letrozole cycle. My doctor gave me 5 milligrams of letrozole. I got my ultrasound done on day 11 to see follicle growth, and it looks like I have 1 10 millimeter follicle each on both sides and a few tiny follicles that are growing. Here are the few questions that I have. Number 1, is it normal to have only 10 millimeter follicles on cycle day 11? Is it because of my high AMH and low BMI? When do you think my follicles will be ready for the trigger shot? Should my doctor increase the dose for the next cycle? Okay, this is a great question. So I think the question is, why is your AMH so high and why are your cycles irregular? Is it because you have lean PCOS or is this from hypothalamic amenorrhea? The way you find the diagnosis is by doing an FSH, LH level and testosterone level and seeing if there are any, if there's a hormonal imbalance, so to speak, such as the LH is much higher than the FSH, or the LH and FSH levels are super, super low. Understanding what your diagnosis is will then allow you to create a really logical roadmap. If you have hypothalamic amenorrhea, for example, taking letrozole a lot of times just isn't going to work, because when you swallow a pill, it relies on your brain being able to talk to your ovaries, to tell your ovaries to grow eggs. And if your brain's not doing that, what's going to happen? You're going to be frustrated, and you're going to be going in and going in and going in and finding out that your eggs are still 10 millimeters. Not your eggs, you know what I mean, your follicles. So ask your doctor, is this lean PCOS or is this hypothalamic amenorrhea? And what are the chances that Femera is going to work for me? If you were my patient, I would also add other things after obviously figuring out what the possible diagnosis could be. We would talk about adding things if it's lean PCOS, adding dexamethasone. I also would add naltrexone and a blend of supplements. Again, it just depends on whether this is lean PCOS or hypothalamic amenorrhea. And then if, for example, 5 days of Femera didn't work, I would consider 10 days, and I would also consider increasing the dose. I totally get and I totally respect what your doctor did. It sounds like your doctor is extremely logical and careful and brought you in early to make sure that you're not going to have an egg explosion. No one wants an egg explosion on their hands, and you know what I mean. With an AMH of 21 and with the number of follicles you possibly had, I bet your doctor was like sweating like bullets, hoping and praying that you wouldn't show up with like 10 follicles with severe ovarian hyperstimulation syndrome just from Femera. And it seems like since that didn't happen, my gut is that you probably have HA, which is hypothalamic amenorrhea, and you might benefit from acupuncture, for example, and adding some of the other supplements that I mentioned, and then perhaps consider a very low dose of Menopur, which is a combination of two hormones, LH and FSH, to kind of talk to your eggs directly so they can start doing what they're going to do. I bet your doctor would agree with me that there's no ovary that won't talk to him when you have the number of follicles that you have. And it's just a matter of figuring out the right dose and the right recipe for you so that you will be successful. But hang tight. It's really annoying because when you have that number of follicles, you feel like it should work, and it will. It's just a matter of, like I said, finding the right recipe for you. Okay, here's another question. And it's the last one until I get to your chatted questions. Here we go. I recently have gone through an egg retrieval. 29 eggs were collected, 15 were mature, 4 made it to blast and sent to genetic testing. Out of the 29 eggs retrieved, only 1 egg is good. All the other eggs came back abnormal, or the embryos came back abnormal. My heart sank. I'd like to know if there's any way I can set up time to figure out what could potentially be, or I want to hear from you what could potentially be the problem as far as what is wrong. On top of this, we had a pregnancy that resulted in a chromosomal issue. We knew this early on. And so we are really frustrated and we're really, really sad. What would you do? So this is the thing. I'm sorry that you've gone through that. Having 4 blasts and only having had 1 that's normal is really hard, especially for people who've gone through traumatic pregnancy histories in the past, because it's kind of annoying for a doctor like me to be like, oh my God, I'm so excited there's 1 embryo that's normal. But to delay what you really want and have to go through the more cycles, I totally get it. I mean, it's really devastating. While you want to focus on the positive and be happy about what you have, it is obviously going to still be sad when you're not able to achieve everything you need in 1 cycle. So for this patient, what I would say, or this person who's messaging me, I would say, I really want you to think about embryo diamonds. And what I mean by that is find out the A and the M, which embryo is abnormal, what the abnormality is. Is it related to something that you've inherited? Probably not. And if any of the embryos are mosaic, was mosaicism analyzed in the report? Is it possible that of the 4, while 1 might be normal, is it possible that any of the other 3 could be mosaic? And I think that's something really important to talk through with your doctor. And for all of you guys who are listening and watching, it is very important for you to talk with your doctor about their policy and procedure for reporting mosaic embryos and what they would do if you had one. And if there isn't a policy, you need to ask for them to create one for you so that you are given you have all the information you should have about your embryos, and you're not discarding a potentially normal embryo that could be deemed abnormal when it's truly mosaic and could turn into a healthy pregnancy. So thank you for sending your question. Okay, guys, I am now going to transition to your live chatted questions. I'm going to start at the beginning, and here we go, starting at the top. So first question is, my doctor plans to use Lupron trigger only 40 IU. Since I will go through the frozen cycle, is this trigger shot reasonable? And when would the estimated trigger shot time be? How many eggs would you? It stops at would you. Okay, so when it comes to a Lupron trigger, if you have a really, really high estrogen level, it's the safest thing to do. However, sometimes I add the Lupron trigger with a low dose HCG trigger at the same time with other medications like bromocriptine and Femara and ganirelix even after the egg retrieval to suppress the ovaries and prevent severe ovarian hyperstimulation syndrome. You can have a trigger failure from Lupron resulting in no eggs retrieved, and it's really awful and annoying when that happens. It's like super devastating. So that's why sometimes I add, depending on the situation in the case, a little bit of HCG, even sometimes 500 units or 1500 units, because then I know that I will get mature eggs. And if I can support the patient with all my little tricks and tips, like whey protein, whey is WHEY protein, like 60 milligrams or grams a day. I can't remember which one it is. But all of these things, in addition to the Lupron trigger, can potentially help reduce your risk of severe OHSS and give you a lot of hopefully beautiful, mature eggs. And then ask your doctor this question, because there are many different Lupron protocols as far as triggering patients. And you should ask, why did you choose this Lupron protocol for me? What is the number of mature eggs you expect from my case? How many healthy embryos do you think I will get? And how many IVF cycles do you think I will need for the family size that I want? So that's all part of the process of going into an IVF cycle fully informed about your diagnosis, what your expectation should be, why you're taking what you're taking, when you're taking it, and how it's going to make you feel. So those are the kinds of things, if you guys don't know that you could be asking these questions, now you do. Okay, next question. I'm having my IUI. What do you recommend, like vitamins or foods, or what can higher my chances? So as far as IUI goes, I would say practice makes perfect. I just came up with that. So don't save up sperm. No one likes saved up sperm. It's gross. It's just gross. It's a bunch of dead sperm sitting in a tube. So just make sure that if you're in a heterosexual relationship, that you guys are not necessarily having a sexathon. I know that that's not realistic after you've been trying for some time, but make jokes about it. Make it fun. You know, bring the, bring your mojo back. Do something to make the process fun and not feel like work. Take away the temping. Try and take away the tracking. Sometimes checking ovulation is something that I ask my patients to do, but try not to be so methodical about it. And there's really no such thing as a sex emergency. So if you guys are in the mood, like, don't sweat it. And then if you feel like sweating it, then sweat it. And then always listen to your doctor. So if you're a patient of mine, I tell you to have sex at least starting cycle day 10 every other day until I see you for your follicle check. And believe it or not, every day is okay too. But don't ask me if you want to have sex every day, multiple times a day, and I don't really want to know that. La, 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 la. So when you come in for the follicle check, I'll tell you if I want you to have sex again, when to take the trigger shot, and when we're going to do the IUI, and whether I think a double IUI could be helpful or not based on your situation. As far as vitamins or foods, antioxidant diet, plant-based, drinking lots of water, sleeping really well, and just trying to find joy in every day. Okay, here's another great question. If we took inositol, metformin, and CoQ10 for trying to conceive reasons, when can we stop taking once pregnant? And I just think it really depends on your situation. I have patients who I ask them to take all three. There is evidence in the literature about the safety of these medications in pregnancy and how they can help, especially patients who have PCOS. They've been shown to be helpful as well for patients who might be at high risk for preeclampsia. So talk to your doctor about that and see what they recommend. But there are cases where I do recommend CoQ10 even during pregnancy. Here's another question. During the IVF stim process, is it possible for some follicles to shrink at the later stage? Many thanks. So I don't know that follicles shrink per se at the later stage. Sometimes the other follicles get so big, so it kind of pushes against the other follicles and makes it look like they shrink. Sometimes you can have a cyst, for example, that starts to shrink. You thought it was an active follicle, but it was actually a cyst, and that's kind of annoying. But sometimes that can happen, so that's why it looks like they shrink. Here's another question. Was on Orlissa for 6 months. For those of you guys who don't know, Orlissa is an oral form of a medication that's very similar to Depo. Lupron is a shot that can shut your body down and put you into a medical menopause. So it's now in a pill form. I was on it for 6 months, had endometriosis excision surgery on month 5, switched to birth control pills for 2 weeks. My first IVF cycle was canceled with only 2 to 3 dominant follicles. Are my ovaries super suppressed? And the answer is, from my standpoint, it sounds like your doctor felt like doing the endometriosis surgery was really important before your IVF cycle. I have had patients who have gone through Orlissa endometriosis surgery, and what I do is I check AMH levels beforehand, and then I check AMH levels afterwards. While endometriosis excision surgery is known potentially not to reduce your ovarian function with a really, really good surgeon, but the thing is that no matter how great your surgeon is, sometimes they can't help and your AMH level will go down, and your ovaries might result in, or you might have less eggs after your surgery. So super important to interview your doctor. And I know you already had surgery, and I bet you interviewed your doctor and were super thorough about the decisions that you made and what you did. But my thing is, let's figure out what our diagnosis is now. What is your AMH? If your AMH is 0.3 or 0.4, for example, then our expectation should be 3 to 4 eggs. So getting 2 mature eggs would be a great outcome. So go for it. It wouldn't be fair to tell someone who had an AMH of 0.2, well, I really want you to have 10 eggs. Well, of course you would want that, but the reality is it just won't happen. So find out what your AMH is now and try to consider no birth control pills. So completely take any meds that could potentially suppress your ovaries and see if what your doctor thinks about that. And maybe being off birth control pills for 2 months could help you. I know that it might affect your endometriosis and there's a higher chance that it might recur. However, this might be the best way for you to get more eggs, to listen to the signals that you're sending your ovaries when you're doing IVF. Here's another question. How much folic acid do you recommend? It also depends on the patient. It depends on your diet. You guys have all heard that saying, medicine, food is medicine. So a lot of patients around here are eating healthy grains all day long. So telling them to take, let's say, 4 milligrams of folic acid or folate doesn't make sense. I recommend at least 1 milligram of folate or 1,000 micrograms. How can you improve sperm health? Well, I think of a little sperm cell with little dumbbells going like this. So just the same things that you can do to live longer will increase sperm health. What are they? Eat healthy, exercise most days of the week, decrease stress, all those kinds of things, sleep well, and then obviously avoiding the lifestyle stuff that can make our sperm really sucky, like drinking lots of alcohol and smoking lots of weed. Like, those things are no-nos in my book. And also anything that contains nicotine. Taking supplements like high-dose antioxidants can help some men as well. Here's another question. Do you recommend taking L-Arginine before transfer? What dosage and how long? Yes. In patients who have thin linings, I have found that it can be helpful. Otherwise, I don't necessarily have patients take L-Arginine as a supplement during their frozen embryo transfer cycles. Hi, Dr. Aimee. Please answer my question. I will. I had 2 cycles of IVF and ICSI, no fertilized egg. One had 2 eggs and one with 3 eggs. They didn't give me any reason why not become fertilized. So an egg that doesn't fertilize typically isn't fertilized because of some sort of egg abnormality. There are certain technologies that can allow you to see what the egg abnormality is when you're doing ICSI. For example, the spindle view is something that an IVF lab might have and allows them to see the spindle in the egg and see if it's normal before they inject the egg. It's a pretty cool technology. It's been out for, what year are we? God, 15 years. So it's pretty old. And some people have it. So it's really cool if they have it and they can look and see. Other thing to ask your doctor if there are any physical characteristics of your eggs that make them think that they're lower egg quality. Are they dark? Are they grainy? Do they have vacuoles? Like, those are the things you want to ask your doctor, because if the quality of the eggs are low, now you want to start talking about what would we do if this next cycle didn't work? And sometimes you want to do that before you put your body through another cycle. And ask your doctor also, what are the chances if we do this again that the same thing might happen? Next question, let's keep going. How many beta ultrasounds do you do before transferring your patients to your OB? Are IVF pregnancies always considered high-risk pregnancies? Great question. So every single patient that comes through my door is VIP to me. VIP means very important pregnancy. You guys, we're in a pandemic and there are lots of headlines out there. One of the headlines that's killing me right now is the increased risk of stillbirths. I don't want any of my patients to have a stillbirth. I know it's not in our control, and I know sometimes things happen that are not in our control. But the one thing that I can control is to make sure that my patients get amazing prenatal care. The last thing you want to do is call your OB and say, I don't feel my baby moving, and have them say, well, it's COVID, don't come in. I'm sorry. you need medical care more than ever right now. You need to have frequent prenatal visits. You need someone monitoring your baby, doing growth scans. And if you're over a certain age or have certain medical issues, for example, a higher BMI or a history of hypertension or diabetes, you need something called antenatal testing. So that's when you go in past around 32 weeks, where you go in and just listen to the baby's heartbeat twice a week, have them look at the fluid and check the growth of the baby. I don't want anyone to take my patients' pregnancies for granted, and I certainly don't take them for granted at all. So I'm kind of a frequent checker, if you probably couldn't tell. So if you're a patient of mine, we do a pregnancy test, HCG and progesterone, 8 days post-transfer, 10 days post-transfer, and then 17 days at post-transfer. So I do that because I don't like surprise. I mean, of course I like surprises like we're pregnant. I don't like surprises like we're pregnant and then you show up for your OB ultrasound and you're not. And I know that going from the frequent check of 8-day, 10-day post-transfer and then telling a patient, bye, see you in 2.5 weeks, what happens? We get really anxious and we get really nervous and we really get really scared, thinking that something might be going on with our pregnancy because we have no way of checking the viability of the pregnancy. So that's why I offer my patients that third check. And sometimes I like to do it too, because going into that heartbeat ultrasound, even if the levels are going up nicely, sometimes you might learn things like the pregnancy stopped growing. It's not common. I should say it's also part of the human experience and part of what can happen, even if you have genetically tested embryos. But if it were me, I'd want to know a lot sooner in my pregnancy if the pregnancy wasn't growing normally than at my heartbeat ultrasound. And then I do the first heartbeat ultrasound when a patient's around 6.5 weeks. If you have a history of ectopic pregnancy, I'll bring you in around 5.5 weeks. Then at around 6.5 weeks, if everything looks awesome, I offer my patients, I say, look, why don't you come in every 2 weeks until you see your OB at around 10? Some people are like, peace out, Aimee, we got the heartbeat. I'll see you in 2 years. And other patients are like, oh my God, can I come every day until I deliver? And I'm like, just come in 2 weeks. And some patients I bring back in 1 week due to some, situations that they've had in the past. And then I always tell patients that I'm just like luggage, right? You always know where your luggage is. You don't always need your luggage, but you know where to find it. So I always tell my patients I want to be the first person that finds out if something's going wrong so I can help you troubleshoot the situation that you're in. If you're having a hard time finding your voice or you feel like people aren't listening to you, sometimes I can help you find the right words to say, or sometimes I call people and open up a can of whoop ass. It's true. These are true stories. Let's go to the next question. Dr. Aimee, would you advise on continuing CoQ10 even after egg retrieval for egg freezing, not planning to get pregnant for another year or so? Is it advisable to take CoQ10 for the whole year? It's advisable to take it for your whole life. I would take CoQ10 until you're done having babies and even beyond, because it's an anti-aging supplement. So definitely. As far as the amount, anywhere from 300 to 600 milligrams would be great. And yes, someone is mentioning that it should be in the water. And I agree, it should be in the water. So this is another question from Ladybugs SF. Hi, Dr. Aimee, do you believe the lab embryologist seniority makes a difference in bringing embryos to blast for women over 43? Are there special measures to assist for this? And I would say asking your doctor if they have had a patient over the age of 40 get pregnant with their own eggs. That's an important question. And then you ask them anyone over the age of 42. And a lot of centers say that they won't help anyone over the age of 43. So if you've crossed your 43rd birthday, they won't offer you IVF with your own eggs. Luckily, in the Bay Area, that is not the case. There certainly are some labs that might say that, but for the most part, women are not discriminated against based on their age once you're, let's say, 43. So the labs in the Bay Area, I know from personal experience because I've had live births in patients who I retrieved eggs at 43 and 44 and 45. So I know that they are very, very technically skilled and know exactly what to do with very precious special eggs. So long story short, only about 5% of embryologists in this country are considered top embryologists. And a lot of them are in the Bay Area. And I do think that the technical skills of the embryologist in the lab can make or break your fertility chances. I have probably 1 to 3 patients traveling here from other parts of the country, not because of me. I mean, they think they're here because of me. But the truth is, it's a little bit of me and a lot of what goes on in the lab. And so I'm truly lucky and very blessed to work with amazing embryologists that make me look good every single day. And I do my best to tell them how much I appreciate them, but I don't think I do enough. I got to figure out a way to show them how much I appreciate them even more. Here's another great question. Are hand sanitizers safe to use while trying to conceive and getting pregnant? You know, that's a really, really good question. I mean, we know, I'm looking at my bottle, my plastic bottle here. I mean, there's probably plastic in here, even though it probably says BPA free. I don't know. Can we really believe that? And is that possibly causing, an issue as far as being an endocrine disruptor? I would say if you're concerned about it, just use soap and water. I have to use hand sanitizer and soap and water all day long, obviously because of what I do. But I can totally see why people out there would be worried about it. I'm not too worried about it. I think it's okay to use hand sanitizer right now. But if you're concerned, just soap and water. Great question. Next, what's the advantage of estrogen priming protocol? So there are a lot of doctors who like that protocol. One of the advantages for them is they can help kind of plan their cycles. They can use really high dose estrogen and use it almost like birth control pills. Another protocol would be to use it after ovulation for about a week. And some doctors feel like they get a better response to medications when they put patients on that protocol. I do use it, maybe like 5% of my cycles are estrogen priming. The reason why I don't use it a lot is I truly love to know what my patient's FSH and estradiol levels are at the start of the cycle, because I feel like it really helps me set the right expectations for the patient as far as what's going on with them. And if you're already on estrogen, you can't check an FSH and estradiol level and think that it's going to be reliable. So that's the issue with that. Next question is, do you think ICSI is mandatory for PGS testing? It isn't mandatory, but trust me, the lab folks, they love it when you do ICSI when you're doing PGT testing. It's just easier for them. It's easier for them for lots of technical reasons. And the thing is this, if I have a patient who chooses not to do ICSI, I'll say that's totally fine. As long as you understand that if you've never had fertilization in the past, the fact that we're skipping ICSI could mean that we might have less embryos this cycle. And then we might have to do another cycle and do ICSI the next time. But typically my patients are extremely reasonable people. And what I do is I say this, if we have shitty sperm, and I do say that, on the day of the egg retrieval, then I'm going to call you. And if the sperm is shitty, we're going to do ICSI. And they're like, oh yeah, that totally makes sense. And they're like, was it shitty? Is it shitty? But typically I've done all the advanced sperm tests up front ahead of time to make sure that we're not in that kind of situation where we're making a game time decision about what to do for sperm. Okay, here's another question. Is the fetal heart rate of 122 beats per minute at 7 weeks, 1 day good? No, that's great. Next question is, AMH still a good, accurate indicator of egg quality even when you have PCOS? Because don't women with PCOS normally have high AMH anyways? Yeah, I mean, if you have PCOS, it doesn't mean you have bad eggs. It just means sometimes you don't ovulate regularly, and that makes it harder to get pregnant. And if you have high testosterone, I think it's important to reduce your testosterone level through medications, exercise, eating healthy, and all that kind of stuff that's known to reduce testosterone levels. But as far as AMH, it tells us the quantity of the eggs. The best test for quality is basically seeing if an egg can turn into a healthy embryo. I know that's really dumb sounding because the only way to do that is to go through IVF. However, the FSH test is a little bit better at telling us about egg quality. AMH is more about quantity, but typically if you're young and you have a high AMH, even with PCOS, or I say especially with PCOS, chances are you still have good eggs. Here's a great question. I did Menopur last cycle and didn't get pregnant. And they've done all the tests and even hormone tests for my PCOS. And they checked my uterus and tubes. I produced 3 good eggs, size 24, and did IUI. Well, it sounds like they did your HSG and your fallopian tubes are open. That's great. And I would say it sounds like you have everything you need to get pregnant. So I would keep trying, keep doing what you're doing because you're responding well. So it doesn't sound like you need to do much different. Next question, should CoQ10 be taken leading up to transfer? If you're my patient, I would say yes. Next question, I had 2 rounds of IVF. I'm 30, I think I already might have answered that. For years, I've been told I have PCOS, but my AMH is only 1.7, which doesn't coincide with my PCOS. Why am I not ovulating? So it could be a thyroid issue. It could be a variant of PCOS. It could be due to a metabolic issue, high fasting insulin, high testosterone. So look at everything. Look at your body size. See what your BMI is. Sometimes just losing 10% of your body weight could potentially suddenly kick your cycles into being regular. Look at your prolactin level. So find out, why are my cycles not regular? And tell your doctor that you want to find other reasons other than PCOS. So just say, if it's not PCOS, what else could it be? Thyroid, metabolic syndrome, like high testosterone, diabetes, like those are the things that can potentially cause irregular cycles that are not PCOS when your AMH is 1.7. And then repeat your AMH. See what it is. Make sure it's not decreased ovarian reserve. See, maybe it's 0.7. So sometimes your AMH can be misleading, and then get an antral follicle count done. All very helpful things to do. Great question. What happens to the embryo after ICSI in the lab? Can you outline the steps and protocols? Air filtration medium, incubator, oxygen levels, what are they checked and how often? Every lab is going to be a little bit different as far as what they do and when they do it. I think I did a show with an awesome embryologist. It's called The Mysteries of the IVF Lab Explained. So go to my YouTube channel and put in Mysteries of the IVF Lab Explained and into the Egg Whisperer Show search engine, and you're going to see all the details of what goes on behind the scenes in the lab. Next question is, high DHEAS a sign of PCOS? And the answer is most likely it is, and there are really easy ways, and I know I say easy, but it just involves a little bit of work of bringing down your DHEAS so that you will have a better response to medications and better quality eggs. Next question, if you're under 30, have PCOS but ovulate regularly, what are your chances of getting pregnant in a given year? If you're ovulating regularly, your chances at 30 are about 85% if you get pregnant in a year. And I appreciate that you saying that. Thank you, and we all love you, and I love you too. Next question is, can your symptoms, nausea, breast tenderness come and go before 8 weeks of pregnancy after seeing a heartbeat? And the answer is, of course. Your boobs stretch, you get used to it, and then you panic like, oh my God, my boobs don't hurt anymore. Am I not pregnant? And I can tell you that's totally normal. That kind of anxiety is normal, because when you want something so bad, of course, I have patients that are like, I wish I could be throwing up. And I'm like, I get it. Like, I don't want you to be throwing up. Like, I really want you to enjoy your pregnancy. I don't want you to be hugging a toilet bowl for the whole pregnancy. But when there's nothing else that you could monitor, of course it makes sense that you want to feel like crap and have your boobs feel really painful. But you're okay. Coming and going is okay. Next question is, 36-year-old with primary ovarian insufficiency, had spontaneous period, and my doctor thinks we can try IUI. I had an ultrasound which showed 2 follicles. I'm on gonal and HCG. What do you think are my chances? So I would say at least 5% or more. At 36, if you have 2 follicles that are growing, if you are my patient, I would say, let's go get them. What are you waiting for? This might be your last opportunity to get eggs retrieved. So really consider and talk to your doctor about retrieving the eggs and not just doing IUI. So I do think that you have a chance for pregnancy. Exactly what it is, or what is it? I mean, each egg at 36 probably has, oh God, let me think, like maybe a 35% chance of being genetically normal. But the problem with IUI is that even if one of them is, the likelihood of it, sticking and growing and turning into a healthy pregnancy is still less than 15%. So my suggestion is talk to your doctor about doing IVF, converting your cycle. Here's another question. If embryos come back abnormal from PGT, can they still go ahead with transfer, since we know sometimes the test is false positive and false negative? The answer is yeah, but ask your doctor about whether your embryos are mosaic. The likelihood of a false positive is really, 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 really low. So talk to your doctor again about their experiences with the lab, and always do a post-test genetic consultation with the genetic testing company that you had your embryos tested with, and ask them these questions. There's so many companies out there, and you deserve this information. You've paid for the testing, so you've paid for the consult already, you just don't know it. But find out more from the genetic testing company and the genetic counselor that they assign you to. Here's another great question. With a high score on the Receptiva test, do you recommend laparoscopy or medications like Lupron or Orlissa? And if medication, for how long? Okay, are you ready? This is my drill. Okay, if your BCL6 is, let's say, less than 2.5 and no evidence of endometriosis, both symptoms are on ultrasound, I would consider doing an HSG to confirm no hydrosalpinx, and then depending on the number of transfers you've done and the number of embryos you've done, or the number of embryos you have, consider maybe medical management. One of 2 options. Number 1, take Femara every single day until your progesterone starts with your estrogen protocol. Number 2, if you've had multiple failed transfers, or you guys know I don't like the word failed, multiple issues with transfers, then consider a month of Depo-Lupron with the Femara. If your BCL6 is over 2.5 and you ruled out a hydrosalpinx, you can still consider the same options. And when I say Depo-Lupron, I also mean Orlissa. You can use them interchangeably. If your BCL6 is, let's say, over 3, I usually recommend 2 months of Depo-Lupron, especially if it's over 3.5. But I've had great success now with just 1 month of Depo-Lupron, even in patients with a BCL6 over 3.5, combining it with Femara daily. So you take Femara 2 tabs daily while you're on the Depo-Lupron, and then you transition right into your estrogen protocol 30 days after the Lupron is out of your system from the first shot. So 30 days after the first shot is what I meant to say. Then you continue your Femara, start your estrogen, and then you transfer about 3 weeks later, and you'll make a beautiful lining most of the time. Like 98% of the time I see a beautiful lining like that. And then also the Anti-Inflammatory Protocol, supplements, diet, all that kind of stuff to help decrease inflammation. Okay, lead into the next question. Any supplements you recommend taking leading up to transfer? How long should you take them and what dosage? Easy. Prenatal, fish oil, vitamin D. And if you have PCOS, the PCOS supplements. If you have endometriosis, the endometriosis supplements. If you think you might need another cycle because the embryo quality is low, the egg quality supplements. Next question is, I had an ectopic last month. 1 tube is removed. A miscarriage in 2018. I'm 34. Husband is 36. So sad and scared. What would you do? Let's find out why your tube was removed. Why did you have an ectopic? Was it scarring from a history of infection, pelvic surgery like appendicitis, or endometriosis? If it's endometriosis, I would suggest that you try and freeze eggs or embryos or both as soon as possible. If it was simply just scarring from a previous infection or just scarring in general not related to endometriosis, perhaps consider taking fertility pills or a combination of pills and shots to help you ovulate from the open side. And be sure to do a hysterosalpingogram to confirm that the open side is truly open, because sometimes whatever affected the one tube that caused it to result in an ectopic pregnancy could also be affecting the other tube. And then before too long, consider IVF treatment so that you've preserved the embryos so that you don't have to worry about your tubes. And I think that's confusing for some people because some people think that you need fallopian tubes to get pregnant. Well, certainly you do if you're home. You don't need your tubes to get pregnant through IVF, and there's no symptom of having blocked fallopian tubes. Like I have patients that tell me, oh, I have regular periods, so I know I have open tubes. I'm like, huh? How does that work? But I get it. Like we haven't done, it's not even a good enough job. We haven't even come close to even like a job of describing and teaching women about their cycles and what happens to their hormones as they're aging. And that's why I continue to do this show, and maybe one day Oprah will call me. Oprah, call me. And I'll just do the show on the Oprah channel. Okay. Are there any prescriptions or supplements to lower FSH before egg retrieval? Is estrogen priming helping with lowering the FSH? Is there anything else you would use on your patients with high FSH? So that's a really great question. Having FSH is really, really tough because, you know, it almost feels like we're being labeled and like we have this like tattoo on our head, like your eggs suck. And the thing is this, it doesn't happen overnight. And just because you have one high FSH doesn't mean all your FSHs will be high. And FSH fluctuates like this to this. And I have patients say, I don't get it. Like all of a sudden my FSH is high. I'm like, no, it's not all of a sudden. It's been happening slowly over time. And only now you caught it. And if you're frequently tracking and trending your levels, you would have noticed that it was high before and we just caught it now. And I think for me, the important thing is how is it trending once it is high? Is it going like this or is it staying like that? Because those kinds of trends help me guide my patients as to what to do next and how. I don't think that there's anything that you can do that truly makes a difference as far as reducing FSH, in that you can falsely or hormonally reduce FSH by taking estrogen, but it doesn't mean that if you've reduced the FSH that way, that the eggs will be better quality. But there are studies that have shown that taking DHEA, not DHA, and I like the micronized version, the micronized version. Theralogics.com makes a DHEA micronized version, and it doesn't result in the high testosterone levels that DHEA not micronized version can result in. And if you use all caps the code TUSHY, TUSHY, you can get the PRC price. So that's a lower price on any supplements on the Theralogics website. So be sure to do that if you're interested. But DHEA can lower FSH levels. You can go to my version of Google, which is PubMed, and you will see nicely published or nicely done studies that kind of show that. Does it happen for everyone? No. Does DHEA cause some people lots of symptoms that are really bad? Yeah, there's some people that just hate how they feel on it. And I would say that in some people it can cause a high progesterone level. So talk to your doctor first before you take any supplements. And if your doctor says, I don't care what you take, well, then do your own research and talk to maybe a naturopath or an acupuncturist and see what they recommend after they've talked to you about your body and what's going on with you and your diagnosis. Thank you for that. Oh, and for my patients with high FSH, I recommend HGH, NAD. True Niagen is the company that I use. I actually take it myself. I don't know if you guys know this, but I'm actually 74. I know I don't look it, but I take all the same supplements that I tell my patients to take for egg quality, and that's why I look so young. Okay, next question. I'm not 74, you guys. Secondary infertility, AMH is 0.6, first IVF round, 2 eggs retrieved, AFC 7 to 10, Menopur 150, Gonal-F 300, what would you change for the next round? So I'm really sorry, that's annoying to only get 2 eggs retrieved with a follicle count of 7 to 10. So I would say this, consider repeating your AMH and see what it is again, because your AMH might not be 0.6, it might be 0.2. And ask your doctor, what size were my follicles when you triggered me? Would you consider going one more day? Did you use enough of a trigger shot? And how is my trigger shot timed? So sometimes in a case like yours, I would go to your eggs to maybe 22 millimeters, and I would even consider a double dual trigger. So what does that mean? Not just using 10,000 units of HCG, but wait for it, 20,000 with a little bit of Lupron to see if we can talk to the eggs in different ways to get them all to mature, and making sure you're doing your trigger shot at 36 hours rather than at 35 or 34 to allow the eggs to fully mature. And then the other important question to ask, if you were expecting 7 eggs and only got 2, did I ovulate? If you're a patient of mine, I will always tell you if something like that happened, because I believe in transparency. I want patients to learn from their cycles and their experiences so that we know exactly what we would do next and what we would do if the next cycle didn't work. And so the chance of ovulating in an IVF cycle is about 1%. It's really low, but when it happens to you, your doctor will know because they will see signs of it in your egg retrieval. So if I have a patient where I don't get the number of eggs I expect, I will go through the same things that I just discussed with you. Am I triggering at the right time? Next time, should I use a higher trigger shot dose? And do I think the patient ovulated? For my patients, I use a lot of antagonists, meaning they take it on the night of the trigger shot. I check a progesterone level. If it's over 1, I have patients also take it the day after the trigger shot. So there's no way that because I don't want to be up at night worrying about my patients ovulating. So the likelihood of that happening is really, really low. Although I have had it happen, maybe like once every 2 years. Some eggs escape me. It drives me bonkers. Okay, great question. Is there anything that can be done for restless legs? Yes. Tonic water. Try it. Quinine. Just a little swig of quinine, and all of a sudden the restless legs go away. And compression stockings, exercise, and electrolyte fluids. Is taking half a Unisom for sleep safe in the first trimester? The answer is yes, but ask your doctor. What would you change if the higher dosage of hormones ended up with 6 big follicles, mature eggs out of 15 in total? I would say, sweet. That sounds good. It depends on your age. So ask your doctor ahead of time what your IVF pyramid looks like. For those of you guys who don't know what the IVF pyramid is, go to my website, to my blog, draimee.org. In the search engine, put in the words, what is IVF? And you're going to see a beautiful pyramid. You can also sign up for my IVF class. My next live class is September 14th at 4 p.m. and I am a good time. It is like a rip-roaring time where you're just going to hear lots of jokes and we just talk about IVF, all the nuts and bolts and all the things that you should consider. Next question. My baseline ultrasound shows that I have multiple fibroids. The largest is 2.2 by 1.5 by 1 centimeter. Posterior left. Should I remove or need to treat before the transfer? It really just kind of depends on, do you have symptoms? Do you have intermenstrual bleeding? Is your fibroid within 5 millimeters of the cavity? If there's a chance that it's going to I don't know what the hell I'm doing. Heck, I'm doing. If there's a chance that your fibroid is going to affect implantation and decrease your implantation rate, get it out of there. But the best way to get it out of there is to do it hysteroscopically. So that's with a really tiny, cute little camera that just sneaks right up into the uterus and you can just remove the fibroid that way. You don't need a laparotomy surgery for 99.9% of fibroids that are less than 2 centimeters. So I have my rule of 5. If a fibroid is 5 centimeters or larger in size or within 5 millimeters of the cavity, I always talk to patients about removing it first. Just because of my rule of thirds, a third of fibroids will stay the same size or shrink in pregnancy, and the last third will just really annoy me and grow in pregnancy. So 2/3 of the time, Basically, when you're pregnant, nothing much happens with your fibroids. A third of the time, they can, cause some trouble. And typically, it's the larger ones and the ones closer to the cavity that can cause trouble. Next question is, what is the predicted AFC in patients with PCOS at 35? So just kind of depends. I mean, typically, if you're 35 and you have PCOS, you might have 20 follicles. And if you're 40 and you had PCOS, you won't have 20 follicles. Maybe you'll have 10 follicles. You don't necessarily stay at 20 even when you're 40 and you have a history of PCOS. Great question here. Does estrogen and progesterone make you gain weight? I eat a low carb, low sugar diet, and I run at least 2 miles a day, but I have been gaining 1 pound per week since I started getting ready for my FET. Okay, this is the thing. These hormones, estrogen and progesterone, don't have calories in them. While that sounds like a really smart ass joke, like, of course they don't make you gain weight. My thing is this. They kind of change your metabolism because they obviously affect thyroid metabolism. So in a patient who's like, dude, I'm eating like nothing and I exercise like crazy and I'm still gaining weight, I'm going to be like, okay, let's check your thyroid and make sure that the estrogen and progesterone isn't messing up your thyroid function, because that's something that's really important for me to know. And then, if you truly are like eating really healthy and exercising every day and you're still gaining weight, it could be water weight and it could be just from the hormones and not a big deal. But if you're gaining like 5 to 10 pounds, then obviously the hormones are changing your metabolism, and I would say don't sweat it. Now's not the time to worry about that, and everything's going to go back to normal in due time. But the answer is yes. Those medications can totally mess up your metabolism and make you gain weight. Okay, my PMS symptoms have gone away since starting acupuncture. Is that good or bad for fertility? That's awesome. Yay, that's the point. PMS sucks. Acupuncture can help. I don't know how. They probably don't even know how. Maybe they do, but that's a good thing. During the egg retrieval time, is it possible to remove polyps and our fibroids on the backside of the uterus as well? So I wish I could do like a threefer. I wish I could be like, I'm gonna do your egg retrieval, and I'm gonna get you a pedicure, and I'm gonna do your manicure, I'm gonna do your hair before you wake up. And I do say that. If you're a patient of mine, I think I said it yesterday morning, I was like, you already had your nails done. Now I'm not gonna do your nails while you're asleep. So the answer is no. I mean, there probably is a center out there that can remove polyps while you're asleep for your egg retrieval, but for the most part, we just do what we're meant to do, which is go on our egg hunt. And then we set you up for your procedures that are needed to prepare for embryo transfer later. Okay, next question. Any information on why my embryos created vacuoles in which out of 27 eggs, 22 were mature, only 5 made it to day 1, and we lost another, leaving us with 4. I had a day 3 transfer with 2 8As. Well, first of all, that's awesome that you had 2 8As. I really hope that your transfer works. And if they were 2 8As on day 3, chances are pretty good that you might have, I don't know how old you are though, that you might have day 5 blastocyst. So the way I think about it is this: it's probably related to some gene that you inherited, and I can't do a test to show you what it is. It's probably related to your age and maybe your environment. Remember, embryo quality has to do with age, right? Age, genetics, and environment. See? Simple. These are the things that are not in our control: the age and the genetics. What's in our control is our environment. So do what you can to be as healthy as possible, and always ask your doctor, what does this mean? What do you think my chances are? What are we going to do differently next time? And what are we going to do if this next cycle doesn't work? Next question is, how can we find out about a clinic's lab quality? Well, you ask your doctor and you ask that question. But some of the things that are really important are how long have the embryologists been working there? One of the things that I know to ask is it the same embryologist that's here every single day? How long have the embryologists, for example, been doing embryo biopsy? The other thing, and I did this with Dr. Carol Kircho. We did a podcast together, and it was basically what to look for in an IVF lab. So if you haven't listened to that podcast, find it. And if you can't find it, just message me and I'll send it to you. But we went through all the things that you should look for in an IVF lab and what questions to ask. But I think the number of people that work there, the number of cases that they do, and pregnancy rates for patients over 40, I think those are some of the really helpful things that will tell you that the IVF lab has what it takes to take care of you. What are your thoughts on fetal Dopplers? When is it safe to do? Well, I have patients that want to hear their baby's heartbeat at home with a fetal Doppler. So what I do is I say, buy it, come in. I don't want you to be at home trying to figure that out on your own. I had to go through an OB/GYN 4-year residency to figure that stuff out. I don't expect someone to YouTube it and know how to use that thing. They're not that easy to use. So do the same thing. Buy one if you want one or need one because of your history or your anxiety levels, and then set up an appointment with your doctor if they'll allow that, and say, look, can I set up an appointment around 14 weeks to have you teach me how to use my Doppler? And hopefully they will say yes, and if they say no, then I'm sorry. I'm really sorry. But maybe you have a friend who's a nurse in labor and delivery or something like that who can guide you. But certainly I always want you to take the advice of your doctor. But the last thing I want is someone pushing hard on their belly with their Doppler because they can't find the baby, and they give themselves lots of bruises on their uterus that are just totally unnecessary. Next question. Is it mandatory to inject the medications at the same time daily while prepping for the FET? And the answer is no. If you're using an oil has buildup. Does it have to be the exact same time every single day? No. So I tell my patients, I just froze for a second there. So, but obviously listen to your doctor. As far as the estrogen pills, I give my patients a schedule, 8 a.m. and 8 p.m., for example, and then progesterone shots at 7 to 9 p.m. every single night. Lovenox, if my patients are taking it, is not time sensitive. And then if you're doing the estrogen shot every 3 days, for example, that's also not time sensitive. It could be around the same time within about 2 hours. That's what I tell my patients. Oh, this is a great question. What is the oldest patient you've treated who had successful pregnancy with their own eggs? 45. And I hope to say 46, 47, 48 one day. I'm praying for that. What is the difference between IMSI and Pcos? Which one do you suggest for high DNA fragmentation? Well, first of all, if it's really high, I recommend Pcos and maybe even add Zymo, but also talk about testicular aspiration. So aspirating through a Tessie procedure with the help of a urologist. It just kind of depends, and going through the balls method and making sure that you've done everything you can that's in your control to improve the sperm quality. Next question, what's the optimal progesterone level before an FET? Before an FET, I like the progesterone to be less than 1 before you start progesterone. After your FET, around pregnancy test time, if you're taking vaginal progesterone, at least 8, and I like to get it up to 10, and I have certain ways of doing that. Injectable progesterone over 20, and some people think, it's not like some people think, a lot of people think that if you have endometriosis that you might require more progesterone. So in a patient who has a history of endometriosis, I certainly like to make sure that progesterone levels, if they're using injectable form, is over 30. Okay, next question. I had 2 failed IUIs using Clomid and a trigger shot. Doctor said that some patients will go from Clomid to Femara. She didn't explain why. Do you think I should switch to Femara? I use Femara for everybody. Yes, switch to Femara. I think it's gentler on your system, hasn't been shown to cause cancer. It's actually used to prevent breast cancer. Seems like a win-win to me. What are your thoughts on treating someone with a high BMI, also struggling with PCOS, history of polyps, also failed 4 Clomid rounds? Okay. First of all, I'm sorry, Clomid sucks. Try Femara. We know the Femara works better for women with PCOS. If you have a history of polyps, see what you can do to make sure you don't have polyps back. Get a saline sonogram done. And I've literally had patients that I've had to do 3 polyp surgeries on because they just keep making them over and over and over again. So find out if that's happening for you. As far as treating someone with a high BMI, my thing is this. Women with high BMI get pregnant all the time without their doctor's permission, but certainly it's just important to know what the risks are of getting pregnant with a high BMI. Make sure you have a doctor that will fully support you, be there for you, and not be like, I won't take care of you. So you want to have someone who's just going to be totally on board and rooting for you, and certainly we have doctors in the Bay Area that do that, and I hope you have the same. I think most of us have lots of experience helping and supporting women with a high BMI, just like we have lots of experience helping women with other potential complications in pregnancy. So I would not sweat it. But as far as the issue of getting pregnant, just make sure that you balance the hormones that you can balance. And what that means is this: when you have a high BMI and PCOS, your testosterone level is probably really high, and your hemoglobin A1C is probably really high too. So take your time. Bring down the hemoglobin A1C. There are medications that can do that. Bring down your testosterone. Same thing. There are medications that can do that. And then I bet you're going to respond a lot better to Femara than you were before, and you will have a much healthier pregnancy going into it with low testosterone and a low hemoglobin A1C. Okay, next question is, can mycoplasma or uroplasma cause miscarriage? I personally don't think so. Next question, I'm 36 years old with an AMH of 5.9 and FSH of 9.7, had 6 early pregnancy losses. Should I be concerned that the high FSH indicates poor egg quality? So the answer is it's possible. I would say that the likelihood of there being another issue is probably higher. I would look and make sure that you have ruled out recurrent ectopic pregnancies, especially if they're just biochemical pregnancies. Get your HSG done. Make sure you're not missing a uterine septum, a bicornuate uterus, or something like that. And then make sure you've done, again, I'm just going through the angel approach, anatomy, autoimmune, you already did your AMH, nutrition, genetic stuff like chromosome analysis for you and your sperm source, and then endocrine issues like thyroid issues, diabetes, and lifestyle like BMI, making sure it's normal, and making sure you're not smoking weed. I just felt like saying that. But that is something we talk about. Okay, should I keep taking DHEA after my egg retrieval if I'm not going to transfer 3 months? Why? Right? yeah, I mean, if you've done the work and your embryos are frozen, stop. Just enjoy life. You're done. Your eggs are cooked. Okay. Unless, of course, you want to do more cycles or I don't know why, just stop it. Okay. I've been diagnosed with having DOR. On Monday, I got an ultrasound and already had 8 follicles. Sweet. That's awesome. 8 is amazing. Good job. It's a beautiful cycle. What is a normal protocol for a transfer? What medications are put in place? Okay. So for transfer, basically we're mimicking ovulation. There are lots of different ways of doing that. You can do that by not mimicking ovulation and just doing a natural cycle and relying on your natural ovulation for women who don't have regular periods or for some reason your doctor wants you to ovulate more than 1 egg, and sometimes I like patients to do that. I have patients take Femera to help them ovulate 1 or 2 eggs, so I don't have to supplement with progesterone. I have to supplement with very little. So that's a natural cycle medicated FET. Then we have a fully controlled medicated FET, which are taking medications to mimic ovulation, 3 weeks of meds typically, anywhere from 3 to 5 weeks. All 3 weeks you're taking estrogen, and then the 3rd week you're overlapping with progesterone, and then you continue all the medications through 10 weeks of pregnancy. So basically, it's a lot of work. Yeah. Okay, next question. 3 embryos sent out for PGT. What are the chances of normal versus abnormal? It really just depends on your age. DFI is 32%. How do you pick the best sperm for ICSI? Well, I would do Pcos. Maybe consider putting them through a Zymote chip too, and talking to your doctor about repeating the DFI before you start IVF so that you're sure to make sure that you're doing IVF at the right time. Because if you do it and the DNA frag is really high, and you might not get as many high quality chromosomally normal embryos. And even if you had high quality chromosomally normal embryos, the implantation potential might be lower. Next question, just had my first IVF cycle. 35 years old, AMH 1.5, FSH9, got 6 eggs, all fertilized, yielded 2 blasts, just got 1 abnormal, 1 no DNA. Chances I will get healthy embryos repeated cycle. I think your chances are really good. I think your 1 no DNA could be a normal embryo. The fact that out of 6 eggs, 100% fertilized and you got 2 blasts just tells me you might have not had a good egg sperm combo, but don't count that no DNA detected embryo out. When I have an embryo that's no DNA detected, and it happens really, really rarely, it's 1% of embryos, I'm going to get on the phone. I'm going to be like, did you guys learn anything about the embryo? Anything you can tell me at all? Even the gender? Anything at all? And sometimes they can tell you. They can tell you that, we think it's probably normal, but we can't tell you for sure. Or they'll tell you, we think it's abnormal, but we cannot tell you for sure. But I would always ask, why was no DNA detected? Was it something on the genetic testing company side, in the lab side? I want to know about it. So super important for you to ask that question, and don't fit. I mean, the fact that you had 2 blasts out of 6 fertilized eggs is pretty good at 35 still. And I would suggest doing another cycle if you can with HGH priming and all the egg quality supplements we talked about. And then make sure you've talked to your doctor about checking the sperm quality on the day of the egg retrieval and see if there's anything you can learn about that or do differently as far as adding Pixie, for example. Oh my God, you guys, there are so many questions here. I am so humbled. I freaking love all of you guys. And I think that if I tried to finish all the questions that you guys still have for me, I'd be here another hour. And I totally would be, but I've seen a lot of patients today, and I need to follow up with each and every one of them because that's what I do. I send everyone an email summary after each visit to make sure that we always know what we talked about. So I believe in verbalizing, emailing, and writing down plans for all my patients so people know the plan. Right now, we're all walking with masks on our face, and it's just so hard. Like I told the patient the other day, I was sitting drawing her blood, and I said, I'm drawing your blood for AMH. I will get your blood test result tomorrow. And then she emailed me, and she said, what's the plan? And I was like, oh my God, I forgot to email you the summary. And then I said, I thought I told you because I was just curious what happened. And she said, oh, I just heard something about Thursday. And I'm like, damn, masks. So that's the mass story. It just makes it harder to understand. So it's so important for you guys to always ask for a summary of what was discussed in all your consults. And one way to do that is to ask for a copy of the note from that visit with your doctor. That way you can put it in your fertility binder and you always know what to expect next from your clinic. And if you're not getting that, just always ask, what are my next steps? When can I reach out? Because if you're a patient of mine, you know that my car is parked out back and there's a bumper sticker that says, if your period has started, follow me. So you guys, follow me, join me next week.